All right, welcome back to Chapter 3. Chapter 3 on public health oftentimes we kind of take this one lightly or we don't pay a whole lot of attention to it, but if any of you have been paying attention 4 years ago, you would realize that public health is kind of a big deal. All of us survived the COVID era and made it through that, and that was a huge public health issue that everyone had to deal with. Now, honestly, when COVID first hit, many of us were a little worried about how things were going to play out and how bad it was really going to get. None of us really knew, and the sad thing is the government didn't know either. They had no idea what was going to happen or what it was going to, what was going to come of it. And many of us were very concerned we were going to be dealing with something along the lines of this.
What are you doing? Should get into the vault. That's the vault.
We can make it.
No, we can't. Let's go! You heard what Javi said. We cannot open it. They're not alone. We can't open it.
They are coming back. We can't leave them there. Come on. Open the door! Go! Go!
Well, now the reality is fortunately COVID didn't turn out to be anything like what many of us feared or what some of us feared it might be. We wasn't sure if COVID was going to kill us or if the shot was going to kill us or we were all going to turn into zombies or, I know every time I watch this movie I always think, well, I would be Brad Pitt or I would be one of those that wasn't infected, but the reality would be is most of us would be zombies. That's just the way those things turn out. We're not always quite as special as we think we are, and we're all pretty much built alike. So public health is a really, really important thing that we need to think about. But oftentimes our approach to public health and the way that we manage public health is a little backwards. Too often we're reactionary instead of proactive. Instead of planning for those things or preventing those things, we react to those things. But public health is nothing more than the practice of trying to prevent diseases and essentially just promoting good health within everybody, or and especially specific groups of people that may be more prone to things. And public health professionals are, what they're tasked with is they look at the overall needs of the population and determine what is the best use of those resources. We've seen that back in 2020 with COVID, the efforts to do that, the decisions that were made. I've since talked to many physicians that said a lot of the things that they were doing early on in the treatment of COVID actually were more harmful than good, such as putting patients on ventilators and doing those types of things that was the normal routine way of doing things because we just didn't know. Now they handle those things very differently. And of course the disease process of that disease has changed somewhat over the course of time. So this next video is a TED Talk, and it talks about, what I really like about this one is he talks about our approach to how we deal with healthcare in the United States. And I think he's got a valid point that our approach may be a little bit off from where it really needs to be.
For over a decade as a doctor, I've cared for homeless veterans, for working class families. I've cared for people who live and work in conditions that can be hard, if not harsh. And that work has led me to believe that we need a fundamentally different way of looking at healthcare. We simply need a healthcare system that moves beyond just looking at the symptoms that bring people into clinics, but instead actually is able to look and improve health where it begins. And where health begins is not in the four walls of a doctor's office, but where we live and where we work, where we eat, sleep, learn, and play, where we spend the majority of our lives. So what does this different approach to healthcare look like? An approach that can improve health where it begins. To illustrate this, I'll tell you about Veronica. Veronica was the 17th patient out of my 26-patient day at that clinic in South Central Los Angeles. She came into our clinic with a chronic headache. This headache had been going on for a number of years, and this particular episode was very, very troubling. In fact, 3 weeks before she came to visit us for the first time, she went to an emergency room in Los Angeles. The emergency room doctors said, we run some tests, Veronica. The results are normal, so here's some pain medication, and follow up with a primary care doctor. But if the pain persists or if it worsens, then come on back. Veronica followed those standard instructions, and she went back. She went back not just once, but twice more. In the 3 weeks before Veronica met us, she went to the emergency room 3 times. She went back and forth, in and out of hospitals and clinics, just like she had done in years past, trying to seek relief, but still coming up short. Veronica came to our clinic, and despite all these encounters with healthcare professionals, Veronica was still sick. When she came to our clinic, though, we tried a different approach. Our approach started with our medical assistant, someone who had a GED level training, but knew the community. Our medical assistant asked them routine questions. She asked, what's your chief complaint? Headache. Let's get your vital signs, measure your blood pressure and your heart rate. But let's also ask about something equally as vital to Veronica and a lot of patients like her in South Los Angeles. Veronica, can you tell me about where you live? Specifically about your housing conditions. Do you have mold? Do you have water leaks? Do you have roaches in your home? Turns out Veronica said yes to 3 of those things: roaches, water leaks, mold. I received that chart in hand, reviewed it, and I turned the handle on the door and I entered the room. You should understand that Veronica, like a lot of patients that I have the privilege of caring for, is a dignified person, a formidable presence, a personality that's larger than life. But here she was, doubled over in pain, sitting on my exam table. Her head, clearly throbbing, was resting in her hands. She lifted her head up, and I saw her face. I said, hello. And then I immediately noticed something across the bridge of her nose, a crease in her skin. In medicine, we call that crease the allergic salute. It's usually seen among children who have chronic allergies. It comes from chronically rubbing one's nose up and down, trying to get rid of those allergy symptoms. And yet here was Veronica, a grown woman, with the same telltale sign of allergies. A few minutes later, in asking Veronica some questions, and examining her and listening to her, I said, Veronica, I think I know what you have. I think you have chronic allergies. I think you have migraine headaches and some sinus congestion. And I think all of those are related to where you live. She looked a little bit relieved because for the first time she had a diagnosis. But I said, Veronica, now let's talk about your treatment. We're going to order some medications for your symptoms, but I also want to refer you to a specialist if that's okay. Now, specialists are a little hard to find in South Central Los Angeles. So she gave me this look like, really? I said, Veronica, actually the specialist I'm talking about is someone I call a community health worker. Someone who, if it's okay with you, can come to your home and try to understand what's going on with those water leaks and that mold, try to help you manage those conditions in your housing that I think are causing your symptoms. And if required, that specialist might refer you to another specialist that we call a public interest lawyer, because it might be that your landlord isn't making the fixes he's required to make. Veronica came back in a few months later. She agreed to all those treatment plans. She told us that her symptoms had improved by 90%. She was spending more time at work and with her family, and less time shuttling back and forth between the emergency rooms of Los Angeles. Veronica had improved remarkably. Her sons, one of whom had asthma, was no longer as sick as they used to be. She had gotten better, and not coincidentally, Veronica's home was better too. What was it about this different approach that we tried that led to better care, fewer visits to the ER, better health? Well, quite simply, it started with that question, Veronica, where do you live? But more importantly, it was that we put in place a system that allowed us to routinely ask questions like Veronica and hundreds more like her about the conditions that mattered in her community, about where health and unfortunately sometimes illness does begin in places like South LA. In that community, substandard housing, food insecurity are the major conditions that we as a clinic had to be aware of. But in other communities, it could be transportation barriers, obesity, access to parks, gun violence. The important thing is we put in place a system that worked. It's an approach that I call an upstream approach. It's a term many of you are familiar with. It comes from a parable that's very common in the public health community. This is a parable of three friends. Imagine that you're one of these three friends who come to a river. It's a beautiful scene, but it's shattered by the cries of a child, and actually several children in need of rescue in the water. So you do, hopefully, what everybody would do. You jump right in, along with your friends. The first friend says, I'm going to rescue those who are about to drown, those at most risk of falling over the waterfall. The second friend says, you know what, I'm going to build a raft. I'm going to make sure that fewer people need to end up at the waterfall's edge. Let's usher more people to safety by building this raft, coordinating those branches together. Over time, they're successful, but not really as much as they want to be. More people slip through, and they finally look up and they see that their third friend is nowhere to be seen. They finally spot her. She's in the water, she's swimming away from them, upstream, rescuing children as she goes. And they shout to her, where are you going? There are children here to save. And she says back, I'm going to find out who or what is throwing these children in the water. In healthcare, we have that first friend. We have the specialist. We have the trauma surgeon, the ICU nurse, the ER doctors. We have those people that are vital rescuers, people you want to be there when you're in dire straits. We also know that we have the second friend. We have that raft builder. That's the primary care clinician, people on the care team who are there to manage your chronic conditions, your diabetes, your hypertension, there to give you your annual checkups, there to make sure your vaccines are up to date, but also there to make sure that you have a raft to sit on and usher yourself to safety. But while that's also vital and very necessary, what we're missing is that third friend. We don't have enough of that upstreamist. The upstreamists are the healthcare professionals who know that health does begin where we live and work and play, but beyond that awareness is able to mobilize the resources to create the system in their clinics and in their hospitals that really does start to approach that, to connect people to the resources they need outside the four walls of the clinic. Now, you might ask a very obvious question that a lot of colleagues in medicine ask. Doctors and nurses thinking about transportation and housing? Shouldn't we just provide pills and procedures and just make sure we focus at the task at hand? Certainly, rescuing people at the water's edge is important enough work. Who has the time? I would argue, though, that if we were to use science as our guide, that we would find an upstream approach is absolutely necessary. Scientists now know that the living and working conditions that we all are part of have more than twice the impact on our health than does our genetic code. And living and working conditions, the structures of our environment, the ways in which our social fabric is woven together, and the impact those have on our behaviors, all together, those have more than 5 times the impact on our health than does all the pills and procedures administered by doctors and hospitals combined. Altogether, living and working conditions account for 60% of preventable death. Let me give you an example of what this feels like. Let's say there was a company, a tech startup, that came to you and said, we have a great product. It's going to lower your risk of death from heart disease. Now, you might be likely to invest if that product was a drug or a device. But what if that product was a park? A study in the UK, a landmark study that reviewed the records of over 40 million residents in the UK, looked at several variables, controlled for a lot of different factors, and found that when trying to adjust the risk of heart disease, one's exposure to green space was a powerful influence. The closer you were to green space, to parks and trees, the lower your chance of heart disease. And that stayed true for rich and for poor. That study illustrates what my friends in public health often say these days, that one zip code matters more than your genetic code. We're also learning that zip code is actually shaping our genetic code. The science of epigenetics looks at those molecular mechanisms, those intricate ways in which our DNA is literally shaped, genes turned on and off based on the exposures to the environment, to where we live and to where we work. So it's clear that these factors, these upstream issues, do matter. They matter to our health, and therefore our healthcare professionals should do something about it. And yet Veronica asked me perhaps the most compelling question I've been asked in a long time. In that follow-up visit, she said, why did none of my doctors ask about my home before? In those visits to the emergency room, I had 2 CAT scans. I had a needle placed in the lower part of my back to collect spinal fluid. I had nearly a dozen blood tests. I went back and forth. I saw all sorts of people in healthcare, and no one asked about my home. The honest answer is that in healthcare, we often treat symptoms without addressing the conditions that make you sick in the first place. And there are many reasons for that, but the big 3 are: first, we don't pay for that. In healthcare, we often pay for volume and not value. We pay doctors and hospitals usually for the number of services they provide, but not necessarily on how healthy they make you. That leads to a second phenomenon that I call the don't ask, don't tell approach to upstream issues in healthcare. We don't ask about where you live and where you work because if there's a problem there, we don't know what to tell you. It's not that doctors don't know these are important issues. In a recent survey done in the US among physicians, over 1,000 physicians, 80% of them actually said that they know that their patients' upstream problems are as important as their health issues, as their medical problems. And yet, despite that widespread awareness of the importance of upstream issues, only 1 in 5 doctors said they had any sense of confidence to address those issues, to improve health where it begins. There's this gap between knowing that patients' lives, the context of where they live and work matters, and the ability to do something about it in the systems in which we work. This is a huge problem right now, because it leads then to this next question, which is, whose responsibility is it? And that brings me to that third point, that third answer to Veronica's compelling question. Part of the reason that we have this conundrum is because there are not nearly enough upstreamists in the healthcare system. There are not nearly enough of that third friend, that person who's going to find out who or what is throwing those kids in the water. Now, there are many upstreamists, and I've had the privilege of meeting many of them, in Los Angeles and in other parts of the country and around the world. And it's important to note that upstreamists sometimes are doctors, but they need not be. They can be nurses, other clinicians, care managers, social workers. It's not so important what specific degree upstreamists have at the end of their name. What's more important is that they all seem to share the same ability to implement a process that transforms their systems, transforms the way they practice medicine. That process is a quite simple process. It's 1, 2, and 3. First, they sit down and they say, let's identify the clinical problem among a certain set of patients. Let's say, for instance, let's try to help children who are bouncing in and out of the hospital with asthma. After identifying the problem, they then move on to that second step and they say, let's identify the root cause. Now, a root cause analysis in healthcare usually says, well, let's look at your genes, let's look at how you're behaving, maybe you're not eating healthy enough and eat healthier. It's a pretty simplistic approach to root cause analyses. It turns out it doesn't really work when we just limit ourselves to that worldview. The root cause analysis that an upstreamist brings to the table is to say, let's look at the living and the working conditions in your life. Perhaps for children with asthma, it's what's happening in their home, or perhaps that they live close to a freeway with major air pollution, the triggers to their asthma. And perhaps that's what we should mobilize our resources to address, because that third element, that third part of the process, is that next critical part of what upstreamists do. They mobilize the resources to create a solution, both within the clinical system, and then by bringing in people from public health, from other sectors, lawyers, whoever is willing to play ball, let's bring in to create a solution that makes sense, to take those patients who actually have clinical problems and address the root causes together by linking them to the resources you need. It's clear to me that there are so many stories of upstreamists who are doing remarkable things. The problem is that there's just not nearly enough of them out there. By some estimates, we need one upstreamist for every 20 to 30 clinicians in the healthcare system. In the US, for instance, that would mean that we need 25,000 upstreamists by the year 2020. But we only have a few thousand upstreamists out there right now, by all accounts. And that's why a few years ago, my colleagues and I said, you know what? We need to train and make more upstreamists. So we decided to start an organization called Health Begins. And Health Begins simply does that. We train upstreamists. And there are a lot of measures that we use for our success, but the main thing that we're interested in is making sure that we're changing the sense of confidence, that don't ask, don't tell metric among clinicians. We're trying to make sure that clinicians, and therefore their systems that they work in, have the ability, the confidence to address the problems in the living and working conditions in our lives. We're seeing nearly a tripling of that confidence in our work. It's remarkable. But I'll tell you the most compelling part of what it means to be working with upstreamists to gather them together. What is most compelling is that every day, every week, I hear stories just like Veronica's. There are stories out there of Veronica and many more like her, people who are coming to the healthcare system and getting a glimpse of what it feels like to be part of something that works. A healthcare system that stops bouncing you back and forth, but actually improves your health, listens to who you are, addresses the context of your life, whether you're rich or poor or middle class. These stories are compelling because not only do they tell us that we're this close to getting the healthcare system that we want, but that there's something that we can all do to get there. Doctors and nurses can get better at asking about the context of patients' lives, not simply because it's better bedside manner, but frankly because it's a better standard of care. Healthcare systems and payers can start to bring in public health agencies and departments and say, let's look at our data together. Let's see if we can discover some patterns in our data about our patients' lives and see if we can identify an upstream cause. And then, as importantly, can we align the resources to be able to address them? Medical schools, nursing schools, all sorts of health professional education programs can help by training the next generation of upstreamists. We can also make sure that these schools certify a backbone of the upstream approach, and that's the community health worker. We need many more of them in the healthcare system if we're truly going to have it be effective, to move from a sick care system to a healthcare system. But finally, and perhaps most importantly, what do we do? What do we do as patients? We can start by simply going to our doctors and our nurses, to our clinics, and asking, is there something in where I live and where I work that I should be aware of? Are there barriers to health that I'm just not aware of? And more importantly, if there are barriers that I'm surfacing, if I'm coming to you and saying, I think I have a problem with my apartment or my workplace, or I don't have access to transportation, or there's a park that's way too far, so sorry, doctor, I can't take your advice to go and jog. If those problems exist, then doctor, are you willing to listen? And what can we do together to improve my health where it begins? If we're all able to do this work, doctors and healthcare systems, payers, and all of us together, we'll realize something about health. Health is not just a personal responsibility or phenomenon. Health is a common good. It comes from our personal investment in knowing that our lives matter, the context of where we live and where we work, eat, and sleep matter, and that what we do for ourselves, we also should do for those whose living and working conditions, again, can be hard, if not harsh. We can all invest in making sure that we improve the allocation of resources upstream, but at the same time, work together and show that we can move healthcare upstream. We can improve health where it begins. Thank you.
That's an interesting concept, and it's not really anything new. Dr. Manchanda is really just talking about something that we've been talking about for a number of years. It's just those elements of community medicine. And the community paramedic would also play a major role in that, similarly. Now, I know what some of you guys are thinking. You're thinking that this may significantly change the way that providers have to do their job and those kinds of things, including physicians. It really didn't. If you listen to the story that he told about Veronica, what happened is a low-level provider, and it may not even been a provider if I remember correctly, it may have been more of a tech or something along the lines, went in the room and just started asking some very specific questions of Veronica about what was going on in her situation, her living conditions and all of those kinds of things, and really got some key elements of the assessment of the big picture of what's going on. It really reminds me of the movie I, Robot. In that movie where Will Smith's character is talking to the hologram at the beginning of the movie, and the hologram is his mentor that had recorded the hologram before he died. But anyway, you'd have to watch the movie, but he's communicating with this hologram and asking it questions. And the hologram at one point in time says, "You must ask the right questions." It tells him he needs to ask the right questions in order to find the answers that he's looking for. That's very true of what we do. It's very true of us as paramedics. It is essential that we ask the right questions. Our entire treatment approach relies completely on our assessment, what we discover about this patient, and it's much more than hooking somebody up to a machine or plugging in some wires or hitting a button or looking at a screen. We have to ask the right questions in order to get a bigger picture of what is going on, because it could be your assessment and the information that you bring to the table about a patient similar to Veronica that is suffering horribly from a very chronic condition that's being overlooked or dismissed, maybe because of her status or socioeconomic status. But you may be able to bring something to the table that a physician, when they look at it, they go, "Oh wait, I know what's going on." They're able to connect the dots and put the pieces together. And then, he talks a lot about what happens, the upstream part of things, where we're doing more about preventing and correcting and that kind of stuff rather than being reactionary. There's a lot to be said about that. We would really reduce the healthcare costs tremendously and reduce the burden to the system. Imagine if this Veronica person, if the first physician that had seen her in the emergency room had picked up on this and made those corrective things happen, she wouldn't have darkened the door of the emergency room. She wouldn't have taken a spot in the emergency room, a bed or something like that, in the 8 or 10, 15, however many times that she did, maybe even a lot more than that over the years or the months. So that's why that's important, because it's really going to reduce the burden on it. And that's why it's really important that we take a closer look at the public health system and the threats that are involved in that and what we can do to kind of reduce those threats. Of course, we're all very familiar with the injuries that happen in those, whether they're intentional, unintentional, and then of course the risk factors that are all involved. Obviously, most of the injuries that we see are unintentional. A lot of times those injuries happen in children, and it is the leading cause of death in children 19 and under. They also have a much lesser ability. Of course, the younger they are, the lesser their ability is to protect themselves from harm. They just don't have, the internal mechanisms, the bone structures, the musculature, or even sometimes the coordination to stave off or prevent an injury or avoid an injury in a given situation. Of course, several risk factors can be age, sex, socioeconomic status, developmental stage is a big one, and of course the family environment as well might predispose some kids to the likelihood of unintentional injuries. In 2018, it says more than half of all Americans had at least one chronic illness. And it may not sound like a lot, but we're talking, that's 150 million people, 150 million plus, probably more like 160, 170 million, have at least one chronic illness that they're dealing with. Now, that's a diagnosed chronic illness. I would bet there's probably more than that, because there's many that are undiagnosed, just because the symptoms are so subtle, or the patients just choose to ignore those symptoms and not take them seriously. Some of them have multiple chronic illnesses. And when they do, typically they have a worse health-related quality of life because of those illnesses. Much higher healthcare costs, as you can imagine, and of course an increased risk of death goes right along with that. So, when we talk about acute illnesses, of course COVID-19 always makes the list, and the reason why COVID-19 was an acute illness is because nobody expected it. It just kind of came out of the blue, and it happened suddenly. So we always have to be on the lookout for those types of things, but not overreactive to where that we're making everybody get tons of vaccines and all those kinds of things. Where there's a place for those, but we have to do that with the eyes wide open. So there's some other public health threats as well. Of course, water, seafood contamination things. Salmonella in a salad, that everybody ate after church on a particular day, and we've got half the community that's sick. Radiation leaks like they've had in Japan and Russia and a few other places, when nuclear power plants get damaged. Lack of sanitary conditions, when the tidal wave tsunami hit Haiti and caused so much damage there, the sanitary conditions weren't great in the first place, and everything just devolved into a much, much worse place to be. And of course, increased incidence of cancer after major incidents. I saw something this morning that they said that we've lost more firefighters due to the post 9/11, the post 9/11 than we did in 9/11 due to the exposures of all of the things they were exposed to. Of course, they, even if they would have known the risk, I'm sure all of them probably would have taken it on anyway and just went ahead and done it regardless. But we've lost more firefighters since 9/11 than we did on 9/11 that are directly related to 9/11. Of course, all of these public health threats cost money. It costs money in a different ways, not just financially. But the years of potential life cost, if we use the life expectancy of 75 years, we can deduct the age of death from that age. So if we lose somebody, then that's the life lost, the years of potential life lost. And then we can multiply that sum of the total deaths at that age. And that'll give us a number of the years lost of potential life. Lost years of earning income, paying taxes, multiple other contributions to society, and all of those things are important. Say you've got, somebody's trained for years to be a physician, and part of their schooling was actually paid through Pell Grants or other types of funding assistance, or maybe even student loans. If they die unexpectedly, not only do we lose that physician and the care that they would provide, but we would lose the income that they would earn, the taxes they would pay, all of those kinds of things that would contribute back into society. And that's not just true of physicians, that's true of anybody, whether they're, working a regular 9-to-5 job, or they're, a doctor or a lawyer or something like that, or a millionaire. Also, medical conditions result in a lower potential life loss than trauma. So while medical conditions are, the likelihood is lower, you won't lose as many years, it still is a contributory factor, though not as impactful as trauma. We're always in a position to where that we can help contribute to a teachable moment. We can articulate and reinforce some of the safety things and messages when opportunities come up. So when we come across a particular situation, we might be able to teach somebody, well, maybe next time you do this instead of that, or hey, this type of rug that you have here it's not a very safe rug for someone using a walker all the time. So you really need a rug like this, or no rug at all, or those types of things. And of course, we always have to use good sound judgment in what we're telling them, and we have to be sensitive to the situation. But we can be preemptive. We can fix things. There's times when you can go into someone's residence for a completely unrelated thing, see some sort of a safety hazard that may be related to, the people or persons within the home, and take an opportunity to teach them. They may or may not listen to you. Most of the time, in my experience, they're grateful because they didn't know. Especially the older that they are, and the more helpful that you can be with some of those things, it's really helpful. Obviously for us, it might be a little selfish. It's like, well, I'm going to teach them this so I don't have to come back here at 3 a.m, to pick them up off the floor, or, with the fire department to put their house out of, that's on fire, So those kinds of things are really helpful. We should also play a role in prevention. Promote those things that are actually going to improve health and safety outcomes. Right now we have a really big, it seems like a growing group of people that are choosing not to vaccinate their children with any vaccinations. And it's debatable, and I'm not necessarily saying what somebody should or shouldn't do. That's entirely up to them, and it's their choice. However, we're starting to see an increase of measles and mumps starting to show back up that we'd never had. That those things were nearly eradicated in the United States, and now we're seeing an incidence of those starting to come back. Now, regardless of how you feel about those illnesses, they can be very bad. They can be harmful and debilitating to children, and even adults if they catch that. So it's things that we need to make sure that we're making clear decisions and not just knee-jerk decisions when somebody's making those, and not necessarily am I pointing this out so that any of you go out there and you try to tell a parent how to take care of their child, or whether or not to vaccinate them, just to let them know, if there is an outbreak, their child would not be protected from it. And it's not like they could run out and get that vaccine and immediately their child would be protected. Sometimes it takes a few weeks to a month or more before the immunity is built up enough to where that it would be worthwhile. And with MMR, it takes 2 shots. So it's about somewhere around the neighborhood of 2 months before that immunity is built up enough to where that it would stave off, catching that disease if there was an outbreak. So just some examples of how, we should be a part of that prevention. 4 E's in prevention, of course, is educate, enforce, and then we need to have engineering controls in there and economic incentives. This doesn't work with everything, but these the 4 E's are helpful, or it's at least a good way to look at how the prevention process plays out. So educating them, preventing accidents by, with the police, putting measures in place. We have airbags in there, and then, the economic incentives, such as the right training, maybe save some money on your insurance and those kinds of things. So the 4 E's of prevention, that's an example right here of how those kind of play out. There are some automatic precautions sometimes that are put in place. And then, of course, these are those passive interventions that typically work. This one here is talking about, the picture on here talks about passive fire protection. Some of those elements that are put in place that are passive ways of doing things that kind of control an eventuality. For instance, this one talks about keeping certain doors closed, or looking at risk factors, and maybe not having open flames or fires in particular places, that kind of stuff, and watching a checklist. Those are passive ways that we can kind of prevent things from happening. And of course, we still want to use a combination of approach in order to kind of stave off things from happening, is typically the best strategy. It's not just any one thing that's going to work. When it talks about automatic protections or passive protections, I remember I had a car once that had that little automatic seatbelt thing. When you got in there, it would come over and try to strangle you, or you thought you were going to get hung the first time you got in there. That was a passive restraint. Airbags are a passive system. However, when we use airbags in conjunction with seatbelts, that combination approach is the greatest likelihood of helping people. And that's not the only protections within a vehicle that are designed specifically for the occupants, to protect the occupants from injury in an accident. Cars are designed to bend in a particular way or not bend in a particular way. There's a lot of science that goes into building a car nowadays to where the goal is to protect the occupants. And it works out well for the automotive industry, because if the occupant is able to leave and survive that particular accident, they're going to need another car. So they're going to have to buy another vehicle. So keeping the occupants alive is actually a good thing for everybody, including the auto industry. So why should EMS be involved in this public health thing? The primary purpose is injury prevention. And that really should be an essential activity of ours. Yes, that's how we get our bread and butter, is to go on calls, emergency calls and those kinds of things. But trust me, you could do all of the injury prevention in the world and there's still going to be accidents, there's still going to be injuries, things are going to happen. But you might be able to reduce some of that in your community. When you reduce those things in your community, it's your community benefits. People don't miss work. They don't have large financial hits that they take. For instance, when you've been in a car accident and your vehicle's been totaled out. If any of you have ever had a vehicle totaled out, and even if you had full coverage insurance, you know that replacing, you're going to get a certain amount for that vehicle, but then you have to replace it, and oftentimes you're underwater on it. It's going to cost you something to replace that car. It's pretty typical. Primarily, we want to stop these injuries before they occur, but secondary is it's the reactionary part of it. It's after the injury occurs. We really want to try to get things settled at the primary point, but if not, we need to be prepared, because we are the secondary. That's our job. We're the secondary in that. Of course, what's great about us and what's really helpful with us is we're out in the community all the time. We're out and about, and we're doing things. We're intermixed within the community, and there's a lot of us. I think the last count, there was somewhere around 12,000 EMS providers in Oklahoma. Now, that might not seem like a lot, but it actually is quite a bit, because of the way that we're widely distributed throughout the communities, even the small communities. And at times, the medics, as sad as it may sound, may be the most educated person in some of the more remote settings. And they're considered advocates of health, healthcare and healthy living. Oftentimes, we're welcomed into schools and other environments to where that we have the ability to be able to promote health, as this picture kind of shows them. Teaching kids how to do CPR. And of course, like it or not, we're oftentimes considered the authorities on injury prevention, even though the majority of what it is that we do has to do with responding after the injury occurs. We do need to kind of shift our focus a little bit to try to start to think about ways that we can prevent injuries from happening in the first place. So what do we need to do to get involved? There's all kinds of ways that we can promote different types of interventions. There's Stop the Bleed programs, there's Narcan programs, and all those kinds of things that we can, as medics, we can promote and get involved in. Promote immunizations. We're ideally suited to reach a lot of the at-risk populations, because oftentimes we spend a lot of time in those at-risk neighborhoods, the low-income, the impoverished neighborhoods, where they oftentimes, we overly assume that they know how to take care of their health, how to manage their health, and how to prevent injuries and illnesses. Most of the time they don't. Nobody's ever told them. They don't have access to the resources that most people have. Maybe they don't have a workplace that they go to all the time that they can learn of these things that are going on. So medics are really on the front lines of being able to share some of those things with these people that are in these really at-risk populations. Of course, and many of us have some prerequisite training that we're required to do. So how do we do it? How's this work? Of course, it's not easy, and you could probably take a separate class on how to get involved and how to plan things, or how to do more in public health. You got to develop a plan if you're going to do this that's going to address logistical matters, clearly define the roles, and it's going to identify and resolve any issues pertaining to the need for additional training. Clearly explains the procedures and foretells the potential liability issues. I remember a number of years back, I did a bicycle safety training for our community, and it was basically open to anybody under, I think, 10 or 11 years old. And they come up and they did a bike, they did an obstacle course and watched a video and, a few things like that. And we gave away bike helmets and hot dogs and drinks and all that kind of stuff. And we had Safe Kids Coalition and the hospital and a few other places involved. The planning of that, I had no clue what I was doing when I first got into it. But in order for it to be successful, honestly, every one of these steps basically were actually put into play along the way. So it is some work to get those things kind of done, but it is absolutely possible to get it done. Of course, I kind of mentioned this earlier, is the next evolution in field EMS is actually community paramedicine. We're not seeing a lot of it in Oklahoma. Canada is doing a lot with it, and they have a pretty amazing program that they're using that's in place. There's also some mobile integrated healthcare, and by integrated healthcare, it means that there's multiple providers involved in that. Community medicine is similar to that as well, but these are the evolutions of EMS and where EMS is going, in the direction that it's going in. We're pretty well suited for that. And things were really moving in that direction pretty well until COVID hit. And COVID really exposed the shortage of medics across the country. And that really kind of slowed things down with community medicine. I look for that to start picking up speed again, but it's going to be a little bit of time. It's taken a bit to get staffing levels back up to where that they need to be, but they're starting to get there. Also, medics can offer some expanded services for a more proactive approach, such as doing in-home visits, health visits, wound care, and other kinds of therapies, and ensure medication compliance. Now, these are not things that medics are just going to be able to inherently do, just walk in the door and do that. It is going to require some additional training, and all these kind of fall in line with that community paramedicine. So as you guys go through the rest of the paramedic program, you're going to realize that, or you're not going to do any training on wound care, and there'll be some other therapies that you don't know anything about. Well, we're going to talk about, and you guys are going to learn about some emergency medications. There is literally thousands and thousands of medications that you're never ever going to have hear of, until you get out of here, because they're just prescribed medications. So to move beyond where we are in EMS right now, if we take a paramedic that's currently working in the field, there'll be some additional training that's going to be required of that in order to get to that next level. Still working on those things. So in order to know what we need, we've got to be able to know what's going on. We got to know our community. So we've got to be able to collect and analyze the data that's out there. And of course, this is an ongoing thing, and it's systematic. In Oklahoma, they do a fairly good job of that, of collecting a lot of that data and information, so that it is available for various different types of research and to know what a particular community, region, or area needs. And of course, these things can be used to develop some interventions, maybe do some public education things, and that would hopefully prevent some illness or injuries from occurring in the future. And of course, strong surveillance is fundamental to making sure those programs are effective and workable. So the Haddon Matrix is It's a matrix that kind of gives you an idea of how all of this fits together. It's got pre and post, pre-event, event, post-event, and equipment and all that stuff that you need for it. The HAD matrix is it adds the factor of time that previous models didn't have, and addresses some of the causes of injury as well. So it's got the host, the agent, environment, and then how they interact over time, and then the pre-event, event, and post-event. And you can kind of see how this matrix kind of plays out when we see a picture of it right here. So the matrix uses those 9 components to analyze a particular injury. Most EMS providers are trained to respond to the post-event phase, so after it all happens. But medics can compel others to take a harder look at the problem and pursue and implement solutions in the pre-event phase if those things start to come to light. So the thing is this is a way to take the data that we're learning, or the data that we've found, and take a look at it and try to prevent things from happening in the future. So, and this kind of gives you an idea of what that could look like. So, what do you do to get started in your community? You need to understand that the patterns of illness and injury in your community and what their causes are, characteristics of the population and environment, and the types of risks that are present. You can literally move 20 miles in any direction from a particular city or town to the neighboring town and find that all of these things are different, in some way or another. Maybe one town is an oil field town and another town is a factory town, and the illnesses and injuries are going to be different. And it's going to be true of a commuter town, someone that's more of a bedroom community that people commute in and out of to their jobs. Those are going to have different patterns and different types of risks that are going to be present. So it's really important that you know the community that you work in and you know what's going on. It's not just kind of a knee-jerk or a feeling that you have. Of course, you can get this information from the state EMS department, and probably even the health department. Of course, they're one and the same, but they might have some different data in some different areas. And that information is public information that they collect. You won't get specific patient data, but it is public information, the injuries and types and locations and that kind of stuff. So it's one of the things that you can do as a medic beyond any of this is just report the data correctly or accurately as you can, and making sure that you're notating the risk factors and those kinds of things. And that's why it's really important when we talk about in the next chapter or two, we're going to talk about documentation and those kinds of things, and why those things are important, and the way that we document and that we're thorough. One of the things that you're going to hear throughout this program is you're only as good as your assessment. If you don't make a good assessment of not just the patient, but the scene, the situation and all the events surrounding it, you're not going to be a good clinician. If you can't make a good assessment, you're never going to be able to care for the patient in the way that it's really going to matter. So you have to get good at being a detective and assessing the patient and finding out what's going on and getting down to those, even so far as going down to the root causes, as was mentioned in the video. Of course, you got to be able to recognize and report the signs and risk factors of those internal violences, such as abusive situations, whether it's child or parental or spousal or that kind of stuff. There's lots of prevention programs out there for children. Fortunately, there's quite a bit of money, generally speaking, out there. It's just knowing where to find it and knowing where to look. There's even some nonprofit groups that jump on board and help with that. In Oklahoma, it's pretty common, from county to county, that somebody, whether it's a fire department, an ambulance service, or a police department, that's doing car seat inspections and making sure that the car seats that is being used is a a safe car seat, an improved car seat. When they find that they're not, oftentimes they've had car seats donated and they're able to give those car seats out, to those people that need one. Helmet donations, whether it's bike helmets and motorcycle helmets, and of course, lots of fundraising events out there. So if you decide that you want to start a safety program or a prevention program in your community for the children there, just start reaching out. You'll find that a lot of businesses are more than willing to, donate various different things. Just make sure you got a list of what you want when you go to them, and oftentimes they'll help. Cash is always the hardest thing to get. But many of them will donate items and things and different types of stuff. There's Safe Kids Worldwide. It's all part of the Safe Kids Coalition, and there's these coalitions. There's like 400 of them all around the country or all around the world, and their goal is to reduce the prevalence of preventable childhood injuries. There's a Safe Kids Coalition. I believe it's still tied in with Children's Hospital in Oklahoma City. They're a great resource. If you're doing anything with children, they would probably be one of the first phone calls that I would make, because they know the resources. They're going to be able to, turn you on to a lot of other, they have a lot of resources, and they'll turn you on to a lot of other resources that are out there. And then of course, it talks a little bit about the pass along effect, where other members of a child's family benefit from the message originally intended for the child. It's pretty amazing how this happens. I've literally had it happen to me where one of my kids, when they were little, they would bring something home from their school that they were learning in class how to prevent this thing or that thing, and I would look at it and go, wow, I didn't know that. It doesn't necessarily mean that you have to be of a certain socioeconomic class to learn something or to be a part of this pass along effect or for it to impact you. So it can impact any community or any level of children and within the community. So that pass along effect is a big thing, and that's why you encourage these kids to take various things home with them to, they can share it with their parents. Let's see. Priority prevention efforts that are injuries with the highest mortality rate, hospitalizations, and long-term disability rates are the ones that we really want to focus on. Those are the big ones that you'll see the most impact within your communities, but it doesn't necessarily need to be the only ones that are addressed and focused on. 5 steps to a prevention program. Community assessments. Always got to start with an assessment. You can't just say, don't do what I did when I decided I was going to do a bicycle safety thing. We was not going on kids that were getting injured on bicycles, and we weren't having a lot of trouble with bicycle stuff in town. It was just something I was like, oh, that might be cool, let's do that. So I didn't really conduct a community assessment. It was a huge hit, but I don't know that it really had a lasting impact or much of an impact within the community. It didn't really change anything safety-wise of any significance. Most of what we talked about was already being done. But conduct a community assessment. Make sure you're fully aware of the problem, that you can clearly define what the problem is. Set those goals and objectives, what it is that you plan to accomplish with that program, and then plan and test your interventions. Are these things going to work? And then, of course, you implement and evaluate those interventions. My program was a one-day thing, the deal that I did, but a lot of these prevention programs are long-term. They may be, that you go to the school, or you hold a community event every single year, or you do this particular thing every quarterly or monthly, or whatever that is. That can be a prevention program as well. It doesn't have to be a one-off kind of event. It can be a reoccurring thing. And of course, the talks here about some community organizing. Of course, designating a leader and build broad support base. This is something that I promise you, there's somebody within your community that is very good at this, at organizing the community and kind of putting things in motion and doing things. There's always somebody out there. And all these bullet points on here, without reading them off to you, are an essential part of that community organizing. So I talk about this just so that, if you're that person that wants to do something, that wants to organize something or to be involved in your community and do some things to prevent some things, if you're recognizing something that you feel like needs addressed, don't get discouraged. Work your way through a list like this to kind of get to where you want to be, or plug in with those people that are familiar with this, that know how to do these kinds of things, that will kind of get you where you want to be as well. Don't be afraid to jump out there and do something. Even if it's not perfect the first couple of times that you do it, just keep doing it. You're going to have an impact in your community, and it's going to make a difference. And of course, always is the biggest thing is funding, trying to find money, looking for innovative ways. What I will tell you is, in my experience, when you're doing this, is if this is going to be an ongoing long-term thing, make sure that you take that into consideration with funding. Because just because the ABC widget company is willing to give you $1,000 for this thing that you're doing this year, it doesn't mean they're going to give you $1,000 next year. You can't count on those companies, year after year after year. Now that doesn't mean don't do it. That just means don't put all your eggs in that basket. Go to that company and say, well, if they don't, we're going to this company, and we're going to this company, and we're going to this company, and we're going to keep trying until we get that funding that we need so that we can continue this particular thing that we're doing. So funding is always going to be an issue. When big things happen, 2020, all kinds of stuff dried up, or there were all kinds of money. I mean, it was just one way or the other. When the economy's bad, there's not as much money. When the economy's good, there's quite a bit more money. So just bear those kinds of things in mind when you're talking about trying to fund a prevention program. Of course, networking with other organizations provides a whole lot more leverage. So working with another group or organization like Safe Kids Coalition, or you can just probably name off a whole bunch of them, that's going to be helpful. But just remember, there's going to be fat and lean times when it comes to funding, and just make sure you're prepared for that. Also, if you're setting up something, just make sure that of how you're managing those funds, and you're being very cautious about how you're tracking and managing, and you can account for where every penny went of those. Otherwise, if you're not careful with that, you'll be on the news, somebody telling you you're being dishonest about it, even though you were completely honest. You just didn't keep your receipts like you should have. So just make sure you don't get yourself caught up in something like that. All right, so that is the end of chapter 3, and I will see you guys again on chapter 4.